We stopped here on Monday talking about your teeth, and I've mentioned your teeth a little bit. We talked a little bit about primary teeth and a little bit about baby teeth. So I want to talk to you. This is something you're going to look at in lab today. You're going to look at tooth structure. So when you go to the dentist, sometimes you'll hear a lot of these terms. So these terms should sound really familiar to you. So that term crown, that is actually just the part of the tooth that sits above the gum line. And the gum is called the gingiva. And you've probably heard of that too, especially when we talk about a disorder that affects the gums, like gingivitis. I'll show you a picture of that in a little bit. But the crown of a tooth is covered by enamel, and enamel is the hardest substance that we have in the body. It is harder than bone. But what happens is that you have some cells that produce enamel, but as soon as the tooth erupts, those cells die. So this is why if you break a tooth or if you get a cavity, you don't have any cells that can replace that enamel. This is why you have to have a filling, or this is why they have to do a veneer, or they have to add something onto your tooth when you've broken it. Okay, it cannot regenerate. The root of the tooth is the part that's actually embedded in the bone. So it's down in the gum line and then embedded into your bone. And it's connected to the crown by the neck. So I'll show you a picture. So you can see the bone here. Right? Here's all that spongy bone. And so we would say that the root of the tooth is this part from here down. It's everything embedded in the bone. The crown is everything that sits above this pink gum line. And you can see the enamel up here. And then in between the two, this is the neck of the tooth. So it's kind of the part that's sort of embedded in the gum. It's not sticking up and it's not down embedded in the bone yet. Some other things are things like cement. This is calcified connective tissue. This covers the root of the tooth and it helps to attach it to something called the periodontal ligament. Now, I mentioned this ligament in my AP1 class when we talked about a gum facies, which is a type of joint. It's between the tooth and the alveolar socket. So the periodontal ligament basically just helps to anchor the tooth in the socket. So let me go back to this picture. The cement, I'll color it in red, is this stuff right here. It just kind of surrounds the root of the tooth. You can see it just surrounds the entire root. And then the periodontal ligament is this really short fibrous connective tissue. I'll color that in blue. It's this tissue here. That's the periodontal ligament. And it truly is holding the tooth in the socket. Okay. The gingival sulcus, this is the groove between the gum and the tooth. So if we go back to this picture, right here, this little area, and over here, that little groove is the gingival sulcus. Sometimes your dentist will, they have these little probes that have hash marks on them, and they'll take it and stick it in the gingival sulcus and see how far down they can go. And that can tell them whether your gums are a little swollen, or sometimes if you brush your teeth really hard, you'll actually cause your gums to start to recede. And that gingival sulcus will get really, really small. So they can see whether you've got some issues going on by looking at the gingival sulcus. Does anybody's dentist do that? Stick the little thing down in the sulcus? It's uncomfortable. All right, so the structure of your teeth, underneath the enamel, the hardest part of your tooth, the white part, you have a substance called dentin. This is kind of a bone-like material. It forms throughout your entire life. It is softer than enamel, and it's kind of like a creamy color, so it's not super white. So dentin has a more of a creamy color to it. There's also the pulp cavity. The pulp cavity is deep inside. In the pulp cavity, you've got some connective tissue, blood vessels, and nerves. So let me go to this picture. So everything in this picture that's blue, so all of this is all the dentin. Okay. And the pulp cavity is the deepest part inside of your tooth. And you can see there's blood vessels and nerves inside of that pulp cavity. And that pulp cavity is kind of extend down, all the way down, and that's called, where it's extending down like that, that's called the root canal. So that's all the way down there. Now sometimes if your tooth has been injured, or let's say you get a crack in your tooth, or you get a really deep cavity, you'll have a lot of pain in your tooth. And usually the pain is, it's sensitive to hot and cold. So it's really normal for people's teeth to be cold sensitive. You bite something cold and it kind of hurts your tooth a little bit. It is not normal for your teeth to be hot sensitive. So if there's ever a time where it's both cold and hot and it hurts when you have something in your mouth that's cold or hot, it probably means that you might need a root canal. And we'll talk about root canal therapy in just a minute. The apical foramen, I have to erase a little bit here. It is, we know the term foramen means hole. Oops. Whoops. Okay. Means hole. So it's this hole down at the very bottom that's allowing the nerves to come up into the tooth. Okay, that's the apical foramen. So I'll mention, while we're looking at this picture, I'll mention a little bit about a root canal. So when they do, has anybody had a root canal? I have not had a root canal. I thought I needed one though a couple weeks ago. Apparently I was really stressed and I was clenching my jaw at night. I had no idea. And it hurt so bad. I was like, I gotta go to the dentist. And I went to the dentist and he tapped and he looked, and I'm not hot or cold sensitive. And then he took his fingers and stuck them in my mouth and pinched that muscle, the masseter muscle over here. And I went, ah! He said, you are clenching your jaw. You've got to stop doing that. I didn't know I was doing it. But it hurts. When you need a root canal, it is really painful. And again, it's usually you've cracked a tooth, you've gotten bacteria down into this pulp cavity, and it's causing inflammation of that nerve. When they do a root canal, a lot of times what they'll do is they'll drill down into the pulp cavity. And then they take a series of files, and they're these sort of long circular files, and they'll stick it down into the pulp cavity in this root canal, and they'll kind of twist it as they stick it in there. And what they're doing is they're cleaning it out. They're trying to get out all the bacteria, all the infection out of that root canal. And then they'll go to a bigger file, and a bigger file, and a bigger file, until they filed all of the infection and everything out of this root canal. Then they'll squirt it with almost like a bleach solution. It's basically cleaning it all out. And then they'll fill it with a material that's like a rubber material. It's called gutta percha. And they stick it in there. And then a lot of times they'll have to put a cap on your tooth after you've had a root canal. Okay. So I also want to talk a little bit about cavities. I think a lot of people get cavities. Those are super common. Cavities happen when the enamel starts to erode away. And again, enamel is this really hard substance, but bacteria, when they're in your mouth and they're feeding on things like the sugar and the food that's left behind, like between your teeth if you're not flossing, bacteria feed on that and they'll produce an acid. And the acid is what is eroding the enamel away. And so again, you can't reproduce that enamel. Once it's gone for good. And so it erodes the enamel away, and what you're left with is the underlying dentin. So a lot of people think cavities are black. They're usually not black. Cavities are usually kind of a creamy color. When you have one, if the dentist has, I don't know any of the dental instruments, I always call it the sharp pointy thing. If a dentist takes that sharp pointy thing and they're trying to stick it in your tooth and it gets stuck in there, they know you have a cavity. Because they're going into the dentin, which is soft, and that sharp pointy thing is getting stuck in there. Okay? So plaque is what we call that film of sugar and bacteria and debris that sticks to your teeth. And that, the bacteria, they're making that acid as they eat that sugar and all that food debris that's left over. So this is why it's really important that you brush and you floss every single day. This is an image. You can see this, the central incisors and the lateral incisors. You can see the enamel has completely eroded away from the front of those teeth. This is a condition that's really common in very small children. It's called milk mouth. They tell you when you have a child, do not put your baby to bed with a bottle in their mouth. And the reason is because when a baby falls asleep, if they have a bottle in their mouth, they're naturally going to push it out. But they don't always get it all the way out of their mouth. And what happens is the nipple is still in there. It's in that oral vestibule. And the milk is just dripping on their teeth. And milk has a lot of sugar in it. And those bacteria go to town in their mouth. And so it erodes the enamel away. And it's always on the front of the teeth. Okay? So never put a baby to bed with a bottle in their mouth. And then this one, you can see that is a very deep cavity. I told you I would mention gingivitis. Gingivitis is when the plaque, that film of sugar on your teeth, calcifies. Anytime anything in your body calcifies, it means it gets hard. It gets calcium added to it. It's really hard. When that happens, when plaque calcifies, it forms tartar. Dentists will call it calculus. This is the stuff when you go to the dentist for your cleaning, where they take the sharp pointy thing and they scrape your teeth. They're scraping the tartar off your teeth, that hard stuff. The problem with tartar is that it gets in the gingival sulcus and it disrupts the seal between the gum and the tooth. You get a lot of bacteria in there, especially anaerobic bacteria, and it can cause an infection in the gums, which is gingivitis. Your gums get red and angry and swollen, like you can see in this picture. So I'll show you a video if I can find it. I do this every time. It's a little gross. Have you all ever seen like serious tartar removal? Let's see if I can find it. Does anybody work at a dental office? No? Okay. So when someone has a lot of tartar buildup, they have to use like an ultrasonic, I don't even know what it is. It's like a chisel almost. I have no idea what this video is, and this may or may not show what we need it to show. Yeah. So this, you can see, this is like a jackhammer almost. So that's not a tooth, that's actually tartar on the tooth that they're chiseling off the tooth. I told you it was a little gross. Yeah. I had a student who was a dental hygienist, and she said that she's had to do this before, and she tells the patients, it's going to feel like I removed your teeth. But I didn't. I'm just taking out all that tartar. All that. I don't know. There's something, I don't know. It's gross. It makes me sound weird, but it's like watching the Dr. Pimple Popper. I'm like, ooh, it's so satisfying. Anyway. Ooh, that's rough. Okay. See, I couldn't let you go the rest of the day without seeing that. Your eyes are watering. Make it stop. All right. Another gum disease we have is periodontitis. This is a very serious gum disease, and this usually is from an immune system response. What happens is your immune system cells start to attack any foreign organisms and intruders in the body, and especially in the mouth, and your own immune system cells will start to carve pockets around your teeth. And it causes you to start to erode your own bone. It destroys the periodontal ligament, which is what is holding the tooth in the socket, and you start to lose teeth. So your teeth will get loose, they will fall out. The risk factors for periodontitis, a lot of times it's anything that inhibits blood flow. So the most common things are smoking. We know that cigarette smoke decreases blood flow to areas of the body. Also, diabetes. We know that people who have diabetes, a lot of times they do not have good perfusion to certain areas, including the mouth. So that's another issue. And then anything that introduces bacteria into your oral membranes, like a piercing. Those are all risk factors for periodontitis. All All right, so from your mouth, food is going to move back into your pharynx. And so y'all remember there's kind of 3 divisions to your pharynx: the nasopharynx, the oropharynx, and the laryngopharynx. So food, when it moves from your mouth, it goes back to the oropharynx. It should not go up to the nasopharynx. And then from there, it passes down to the laryngopharynx. And both of these, oro and laryngopharynx, they allow for the passage of food and air and liquids. And because of that, the lining that we find here is going to be a stratified epithelium. And that's just, remember, stratified is stratified because you need protection in that area, right? Protection from abrasion and wear and tear. Like when you go to La Grande Fiesta and you eat an entire basket of chips and you barely chew them, you got to make sure that they don't abrade your pharynx. From there, your food's going to move down through the esophagus. And the esophagus is this flat tube. Now, you saw this on the rat. To see the esophagus, you had to take the trachea and kind of turn it a little bit, because the trachea is in the front and the esophagus is in the back. And it's this really flat tube back there. And it runs right behind the trachea, but it continues, it pierces the diaphragm and goes down into the stomach. And it joins the stomach at something called the cardial orifice. And surrounding that opening is a sphincter muscle. So I mentioned to you on Monday that anytime we're looking at this alimentary canal, the muscle layer, it always has 2 layers of muscle, the longitudinal and the circular layer. And anytime you have excess circular muscle, it's called a sphincter muscle, and it can close. So you have this gastroesophageal sphincter. Sometimes we call it the cardiac sphincter. That makes sense because of where it's located, right? If we think of the anatomy, take this off and this off. That sphincter is right here. So it's sitting basically right under the heart. So that's why sometimes it's called the cardiac sphincter. I like to call it the gastroesophageal sphincter. That's usually what I refer to it as, because it's truly between the esophagus and the stomach, which is the gastro. Okay. Now, I've mentioned heartburn already. This is anytime stomach acid kind of leaves your stomach and goes back up the esophagus. We call it heartburn because of where that esophagus is located, right? Right behind the heart is where we find it. So it feels like your heart's on fire. And what causes heartburn? Has anybody had heartburn? I don't think I had it until I was in college. And then it was because I had too much to drink. Probably turn that off. Just once. So excess food and drink, definitely. Sometimes, not even, I'm not saying alcohol in general, but sometimes if you just have way too much to eat, like you feel gross and you go to bed and then you'll get heartburn. So a lot of times it's when you eat too much and then you lay down. It can go backwards. Another one is really spicy food. You eat spicy food and that can cause excess stomach acid creation, and then that can go back up and cause some heartburn. Obesity, running, and ladies, it's bad. Nobody tells you how much pregnancy sucks. I mean, it's great, you glow and all that stuff. But I'm telling you, like my heartburn, it started at like 4 months, and then it got to be so bad. My baby, he wasn't even that big. But I mean, yeah, this is a full-term fetus. Like, look at how much space that baby's taking up. All of your other organs get mushed where they can fit. And so that stomach is getting squeezed. So when I was like at, maybe 35 weeks, I could eat like 1 bite of something. And then I'd be like, well, I'm full. There's nothing else that can fit in here. I'd have to eat like 1 bite at a time every 20 minutes. It was awful. And then I had to eat dinner at 4:30. I felt like such an old person. Because if I ate after 4:30, I couldn't go to bed at 7:30. You're tired when you're pregnant. So I couldn't go to bed because I couldn't lay down because the heartburn was so bad. Oh, the struggle is real. So common with all of those things. Another thing that can cause heartburn, I have a good friend who just had this surgery, is a hiatal hernia. A hiatal hernia is when, now we know what hernias are, right? We talked about these in AP1. It's a tear in the abdominal muscle. But a hiatal hernia is not a tear in the abdominal muscle, it's a tear in the diaphragm. And what happens is part of your stomach starts to push up through the diaphragm. And that can also cause a lot of heartburn. And that requires surgery. Now, in your esophagus, you do have a stratified squamous epithelium to protect from abrasion and wear and tear, but you also have a lot of mucus secreting cells, which help with the movement of that food. Once it gets into the stomach, it changes to a simple epithelium, right? Because by this point, you're mixing the food with stomach acid, it's getting softer, you don't need the protection from abrasion anymore. You do have a lot of those mucus secreting cells, which help to move the food. Now we call that food, that chunk of food that's moving down, a bolus, okay? And the other thing we're going to see in the esophagus is that the muscle layer is going to go from being skeletal, which you have control over, to being smooth muscle, which you do not have voluntary control over. So these are all the digestive processes that are happening in the mouth, right? It's ingestion, which is putting the food in your mouth. It's the mechanical breakdown, like chewing, which we call mastication. Propulsion, which is swallowing. That's a term called deglutition. And then chemical digestion. And there's not a ton of chemical digestion happening here. Maybe a little bit of salivary amylase gets released. Does anyone remember of our 4 macronutrients, carbs, lipids, proteins, and I'm just going to write NA, nucleic acids. Do you remember what amylase helps to break down? Not lipids. Not nucleic acids. Carbohydrates, right? It's going to break them down into sugars, right? Monosaccharides. So you have a little bit of amylase getting released in the saliva, so it starts the breakdown, but it's not complete. And then also a little bit of lingual lipase. What does lipase help you break down? Lipids. That one's easy. Lipase kind of sounds like lipid. So that starts the breakdown of lipids. Now again, in your mouth, you are not absorbing nutrients from your mouth. The only thing you can sometimes absorb in your mouth are some drug agents. There are some drugs that, like anti-nausea medications, that you can just lay on your tongue and let them dissolve on your tongue and they can go into your bloodstream. So there are some that can dissolve in that mucous membrane, but for the most part, you're not absorbing anything from there. Now I mentioned chewing, which is the term called mastication. When you chew your food, your tongue is mixing it with saliva and compacting that food into a little slug or a bolus. This is going to sound weird. Obviously, putting food in your mouth is voluntary, and chewing it is voluntary. But there's also a slight involuntary part to that. So the voluntary part is just contracting your jaw muscle. This is skeletal muscle. It's under voluntary control. But there is an involuntary reflexive part to chewing, and that is just sort of the pattern and the rhythm of chewing that you have. That's involuntary. And that is regulated by some stretch reflexes and pressure receptors in your mouth. So that's why you're not crunching real hard when you're chewing something that's a little bit more liquidy and soft. So your body kind of regulates that involuntarily. The term deglutition is swallowing that food. And this involves the tongue, the soft palate, your pharynx, and your esophagus. So it's a lot of muscles that help with swallowing. 22 different muscle groups that help with that. And there's 2 parts to this. There's a voluntary part to swallowing and an involuntary part to swallowing. The voluntary part is when you contract your tongue. So that's skeletal muscle. You kind of push the tongue up to the roof of the mouth and it starts to move the bolus of food towards the back. Once the food gets towards the back, it becomes involuntary. And this is actually controlled by your brain, and it triggers a swallowing reflex. The difference between the two is the way I think about it. Have you ever not quite been ready to swallow, but sometimes the food gets to the back and you end up having to swallow anyway, right? It happens, to me it happens with my spit sometimes. Like I'll be talking and then it's like, whoop, I had to swallow in the middle of that and I wasn't really planning on it. So there is an involuntary part to that. It's just when that food gets back there, it triggers that reflex. I don't know why they make the bolus of food green in this picture. It kind of grosses me out. We'll pretend it's green jello. So up here, this is showing you the buccal phase. So this is when the food is in your mouth. And you can see that the tongue starts to press towards the roof of the mouth and push that bolus of food towards the back, towards the pharynx. Once the food moves into the pharynx, we say it's in the pharyngeal esophageal phase. And it's going to move down that esophagus. You've got muscles that are contracting, going through peristalsis to squeeze the food down. See, it's squeezing it down into that stomach. Okay. So once the food gets into the stomach, I want to talk a little bit about the function of the stomach. Do you absorb nutrients out of your stomach, out of food from your stomach? No. The only function of your stomach, you can live without a stomach. In fact, people do when they have gastric bypass surgery, right? Doctors take a stomach and make it this teeny tiny little bag, make it really small, and you bypass a huge portion of your stomach. So you can live without a stomach. The job of your stomach is, it's kind of just a temporary storage tank. It's mixing the food with stomach acid. It's liquefying the food a little more. That's it. Okay? You're not absorbing nutrients from the stomach. So it does help to break down that food and liquefy it with stomach acid. And we say that when food gets mixed with gastric juice, we then call it chyme. It is this liquidy, acidic substance. Now, everybody's stomach looks a little different. The size of your stomach, the shape, the position in the body is different. People who are really tall, their stomach usually lies a little more vertical in the body. If you're short, your stomach is going to be more horizontal. So it can be a little different from person to person. You're going to look at the stomach in lab today. So the parts of the stomach up at the top where the esophagus is dumping in. Remember that sphincter muscle, sometimes we can call it the cardiac sphincter. So this part up at the top is called the cardial part. Okay, this is closest to the heart. It's the cardial part. It surrounds the cardial orifice. The fundus is this rounded bulge of the stomach. The body is all this mid portion. And then the pyloric part is the end of the stomach, right before you get into your small intestine. Okay? And at the end, in this pyloric part, you have another sphincter, one of those round muscles that can close, called the pyloric sphincter. And this one I mentioned to you on Monday, this helps to control the emptying of the stomach into the small intestine. You do not want all the food to just into the small intestine. That would be really bad. You would not absorb nutrients very well. So this pyloric sphincter slowly regulates the food going into the small intestine so that you can absorb as many nutrients as you can. You also have some mesenteries that help to tether the stomach and hold it in place. The lesser omentum is not one we've probably talked about before. And the lesser omentum is smaller than the greater omentum. The greater omentum should sound familiar. The lesser omentum basically tethers the stomach up to the liver. So it's coming from the top down. So it's really short. The greater omentum is much bigger. And this is basically covering, it's a layer of fat that covers over the stomach and the small intestine and the large intestine and the spleen. And it has a lot of fat in it. So on these models, you can see, they only have it on half, but you can see this yellow stuff, which always means fat. That's our greater omentum. You can see it's covering almost all of those abdominal organs. So here's a picture from your book that shows the lesser omentum really well, right? So you can see it's tethering the stomach up to that liver. The greater omentum, it does not show very well. It shows a little edge of the greater omentum right there, but they've cut it off. So the greater omentum normally would cover over all of the intestines, the small and large intestines. So we walked through, when we talked about the esophagus, we talked about the layers that we find, the tunics that you find in there. So I want to do the same thing with the stomach. And it's pretty much the exact same thing, right? Throughout the alimentary canal, you have a mucosa, which is on the inside, a submucosa, a muscularis externa, and a serosa. So it's still the exact same thing because we're still in the alimentary canal. However, in the stomach, because it's filled with gastric juice, and what's the pH of gastric juice? 1. Super low. Because it's filled with this really low pH solution, there are some modifications to some of these layers. So the only thing I'm going to talk about in these layers is just the 2 that have the modifications, okay? And those are the 2that I starred. So I'm going to mention the mucosa a little bit and talk about how the mucosa, the lining of the stomach, is different from the lining of the esophagus. And also the muscularis externa. That muscle layer in the stomach's a little different. So for the mucosa, that lining of the stomach, in the stomach it is different because it secretes mucus that is rich in bicarbonate. Bicarbonate, that should sound really familiar, right? We talked about bicarbonate in the respiratory system. Remember, this is how you carry the majority of your CO2 as bicarbonate. What is bicarbonate? Starts with a B. A buffer. It is a buffer, which it buffers pH. See how that could be important? So the mucus that lines the stomach has a buffer in it, a bicarbonate buffer, so that that stomach acid does not eat through the lining of your stomach. Okay, so that makes the mucus more protective. Another thing that we find in the stomach lining is that you have these little holes, these gastric pits. So you can see them up here, all these gastric pits. They're showing you here so you can see down into the gastric pit. And these are basically gastric glands that have different cells in them that do different things. They secrete different things. We're going to talk about these different cells and what they secrete in just a little bit. So we have a mucosa, slightly different in the stomach, has bicarbonate-rich mucus in it and some gastric pits. A submucosa, which looks exactly the same throughout the alimentary canal. And then the muscularis externa in the stomach is a little different. The muscularis externa normally has 2 layers of muscle, right? Longitudinal and circular. In the stomach, it has 3 layers of muscle. It has an extra layer. The extra layer is an oblique layer of muscle, and it really helps the stomach to churn that food more, mix it with that gastric juice. It does a better job of moving with that extra layer and helps with a continuous mechanical breakdown of your food. So I want to go back to this mucosal layer, and I just want to mention the different kinds of cells that are in those gastric glands and just mention what they do. So I tried, for each of the types of cells, I tried to color code them the same color that they are in the picture. I thought that would help. So the mucus neck cells are these sort of darker pink cells, and their job is exactly what it sounds like it is. They make the mucus that's going to line the inside of the stomach. Okay. The blue ones are called parietal cells. These are secreting that hydrochloric acid, that stomach acid. They're making the gastric juice. So that's one thing they're doing. The other thing is they are producing intrinsic factor. Now, I had talked about intrinsic factor at the beginning of the semester, back when we were talking about red blood cells. Intrinsic factor is made by the lining of the stomach, by these parietal cells, and it helps you absorb vitamin B12 out of your food. And what do you need B12 for? No, not energy, not metabolism. We talked about it when we talked about in chapter 17, which was in the the blood. You gotta have it to make red blood cells. If you don't have B12, you can't make red blood cells. So this is why people sometimes can have a type of anemia called pernicious anemia. It's where they're not getting B12 out of their food and they're not making enough red blood cells and they can't carry enough oxygen. Okay? So you gotta have B12 to make red blood cells, but in order to absorb B12, you gotta have intrinsic factor, which is made by these parietal cells. So this is why people who've had gastric bypass, for example, when you have gastric bypass, sometimes they'll do like a gastric sleeve, sometimes they'll actually cut the stomach, but they'll go in and they'll take the stomach, which is like this, and they might put like a sleeve up here and create a little tiny new stomach. And then they reroute the intestine to this little tiny new bag they've created. And you bypass all the rest of the stomach. Those people, when they have gastric bypass, a lot of times because you don't have enough intrinsic factor in this little bag that you've now created, those parietal cells in that little bag can't make enough intrinsic factor. They're usually deficient in B12, and they usually develop pernicious anemia. So people who have gastric bypass a lot of times have to take B12 injections for the rest of their life, or as long as they have the sleeve or the whatever else they have on their stomach. Okay? These purple cells are called chief cells, and they secrete enzymes like pepsinogen and lipase. Lipase is an enzyme that helps you break down which of those 4 macromolecules? Lipids. What do you think pepsinogen helps you break down? Proteins. And then lastly are these little green ones called enteroendocrine cells. The name of that should tell you what it does. Think endocrine system. They release hormones. Okay, so these are releasing some hormones. So these are the 4 kinds of cells that you'll find lining the stomach, and they're all doing something really important. They're either making the mucus and the bicarbonate, or they're making the gastric juice and the intrinsic factor, or they're making some enzymes to help with the continuous breakdown of those big macromolecules, or they're releasing hormones. Now, I mentioned this already, but lining the stomach, those mucus cells, they release bicarbonate-rich mucus. So you do have a mucosal barrier. That's important. It is protecting the lining of the stomach from being eroded away by that stomach acid. You also have in that lining of the stomach, those cells are held together by tight junctions. So they're held together really tight so that gastric juice can't seep out of your stomach. Food can't seep out of your stomach. Nothing's going to leave the stomach, okay? It's a nice tight bag in there. Anytime you damage the lining of your stomach because it's epithelial cells, they regenerate really fast. So your body will regenerate those and replace them very quickly. And in fact, even if you don't damage the lining of your stomach, your body will regenerate the lining of the stomach at least once a week, sometimes twice a week. So every 3 to 6 days, the whole lining of the stomach is being regenerated. Now there is a condition called gastritis, and this happens anytime something breaches through the mucosal barrier. The things that are really common that cause gastritis are peptic or gastric ulcers. And an ulcer in the stomach, a stomach ulcer, is when the lining of the stomach erodes away. It can perforate, it can cause an infection, that peritonitis. You get that infection throughout your entire peritoneum. It can also cause hemorrhaging, so you can bleed out from it. So you have a lot of blood vessels in there. It used to be that doctors used to think that you would get stomach ulcers because you drank too much, you were stressed, you smoked, you drank too much coffee, you ate spicy foods. It was all about lifestyle. So for the longest time, I remember my dad, he was an engineer, he worked for Procter & Gamble, and he used to have stomach ulcers. And he was very stressed, he worked all the time, and the doctor was like, you've got to lower your stress. You've got to lower your stress. And my dad was never a smoker or a drinker. And so, you got to lower your stress, drink less coffee. It was all about what he was eating. Well, we have now discovered that most 70% of all stomach ulcers are not from what you're eating or consuming. It's actually caused by a bacteria called Helicobacter pylori. And so how do we treat bacterial infections? Antibiotics, right? So now we know most of the time when people get stomach ulcers like this, we give them antibiotics to kill off these bacteria, and they're fine, and those ulcers go away. Okay? Now there are other things that can really damage the lining of your stomach. NSAIDs are one, so things like Aleve and ibuprofen. I can't take ibuprofen on an empty stomach. If I do, I will vomit. I can't do it. And I am not alone. There are a lot of people like that. It really damages the lining of your stomach. And they even tell you, if you take ibuprofen or Aleve, they say don't take it for longer than so many days because it will really start to make you nauseous and it really hurts that lining of the stomach. Tylenol is better, right, in terms of that. This is showing you a gastric ulcer, so you can see that hole, that perforation in the stomach lining. This is showing you, this is a scanning electron micrograph of the lining of the stomach. So you can see the mucosal barrier here. Here are those Helicobacter pylori. You can see that they're living in the lining of the stomach and they are eroding away that lining. So again, let's think about what your stomach does. You're not absorbing nutrients from your stomach. It is a temporary storage tank for food. It helps to continually break down the food, so it does help with the mechanical breakdown. It turns that food into chyme and delivers that chyme slowly into the small intestine. You also, remember, you've got some of those cells that help to release some enzymes like pepsinogen and lipase, so it does help with the enzymatic breakdown of some of those macromolecules that I have on the board. It also helps to start to break down your proteins because of the hydrochloric acid, that low pH, denatures and unfolds the proteins you've consumed. And it also makes intrinsic factor. And I'm going to star that one because that is the only necessary function of your stomach. The rest we can live without. Okay? So again, you can live without the stomach. If they take your entire stomach out, you would have to have B12 injections. So this is why we say that the only real necessary function of the stomach is making that intrinsic factor. It's the only function essential to life. And you got to have B12 so that you can make red blood cells. If you don't, you develop pernicious anemia. So again, although you do break down your food in the stomach, there is some digestion happening. Remember, the term digestion means break down. So there is some breakdown happening in the stomach. You're not absorbing anything in the stomach for a lot of reasons. One reason you don't absorb nutrients in the stomach is because the lining of the stomach is coated in mucus. So it is not conducive to absorption of nutrients. It's not even exposed to the chyme and the nutrients, so you can't really absorb through that. The cells that line the stomach don't even have transport mechanisms for absorption. The lining of the stomach is impermeable to water, so you can't absorb anything. And the biggest reason, I think, is because digestion's not done. So remember, these macromolecules that I write on the board, so these 4 macromolecules, in order for you to break these down, they have to be in their monomers. No, in order for you to absorb these, they have to be in their monomers, right? So like carbs, you have to have these down into their monosaccharides. Lipids, they have to be down into fatty acids for you to absorb them. Proteins have to be down to amino acids. And nucleic acids have to be broken down into nucleotides. You're not there yet, right? So remember, you start the breakdown in the mouth. You've released a little bit of amylase, so you've broken your carbs down, but not all the way into monosaccharides. They're probably down into like disaccharides. You still have polysaccharides left. You've released a little bit of lipase, but it hasn't broken fat down into fatty acids yet. That's all in the mouth. When you get to the stomach, you release a little bit of that pepsin, but it hasn't broken your proteins all the way down. And you've released a little more amylase, but you're still not down to monosaccharides. So you're not into the monomers yet. You have not completely broken food down, so you don't have anything to absorb. There are no absorbable units yet, right? So that's why I'm going to star this one, because that's the biggest reason why you're not absorbing out of your stomach. Not only can you not do it, but you're not ready yet, okay? So I mentioned to you that your stomach does release some pepsin. And pepsin helps you break down protein. Again, you're not going to break it all the way into amino acids in the stomach, so it's not complete. But you can break down big, complex proteins into smaller proteins. That's one thing that you're doing. And also, the low pH helps to activate all of that. It helps to denature the protein, and it really helps to start the breakdown. So in adults, the enzyme we release to break down protein is called pepsin. But in babies, it's different. I want you to think about the fact that babies are not eating solid foods. What does their diet consist of? What are infants consuming? Milk, formula, right? And the protein that's in breast milk or in formula is milk protein called casein. Pepsin doesn't do a great job of breaking down milk protein. So in an infant, because they're not getting any other form of protein other than casein, milk casein, there's an enzyme getting released called rennet. That helps to break down the milk protein. So in an infant, in their stomach, they're not making pepsin, they're making rennet. And this is why a lot of times when babies hit about 6 months, doctors say, okay, you can start introducing some solid foods. But you don't just like throw a pizza on their tray table, on their chair. You do a little bit at a time, right? Well, usually do one food at a time. Like, I think I started with pears, and I let my child have pears for a couple of days or maybe a week. And then we did carrots, and then we did peas. And so we would just do one food at a time, because you want to make sure they don't have allergies to it, but also because you got to let their stomach get used to now eating something different, other than just consuming milk and having that milk casing in there. You also have that salivary amylase being released in the mouth. It's still working when it gets down into the stomach, so it's still helping with the breakdown of carbohydrates. It's just pretty limited.